might be number 10 in the Alberta Innovates Health Solutions Institute of Health Economics Breakfast Speaker Series. I'd like to bring greetings on behalf of both organizations, Dr. Lauren Terrell and Rob Seidel, respective chairs of the Institute of Health Economics and the Alberta Innovates Health Solutions, as well as CEO Pam Valentine and Dr. Egon Janssen. And great, they've slowly built over the past year and a half, and I think they've been really useful opportunities to have an opportunity to kind of showcase some lessons from away and reflect on how they might be able to be applied to Alberta. There will be a recording of the presentation, and that is, as well as all our past ones, are available online for you to look at and also share with your colleagues. We're excited today to be able to have some guests from New Zealand who've been able to share some of their findings and results from efforts in clinical pathway development, and similar to some of the efforts that I think we're trying to do here. But I'd like to call on Dr. Rod Elford, who's the co-chair of the Provincial Steering Committee on Clinical Pathway Development in Alberta, to introduce our guests and provide a couple of opening remarks. Rod?
Thanks. A few years ago, a young man called Greg Price died. He died as partly because of complications from his disease, but our system failed him. So this represented a serious fault in our system, and the Health Quality Council wrote a report about it called the Continuity of Care Report, and many of you may have read that. And what it highlighted is that we don't do transitions well. We don't hand over or do interfaces well in our system, to the point that it can have a negative outcome. That report really bothered me. I actually met with his family and talked to them. I'd actually invited David, his dad, to come today. He couldn't make it, but I said, is there anything you want me to relay to this group? And he emailed me last night, and it was surprising. He said he had a concern with the new government. He thought that the NDP would help promote healthcare, but he'd heard that they talked about things like change fatigue and stability, and in his mind that meant they weren't going to change anything. And he was concerned that if they didn't change anything, we couldn't make it better. So I bring you that message from Dave Price. I also wanted to make sure that we focused on families and patients, the reason why that we're in the health system. So I was the person that recommended that Canterbury come visit and talk to you today and throughout the week. Why? My dad told me many years ago that if you wanted to get good at something or learn something really well, find out who does it very well and go work with them. A few years ago, I was very interested in trying to figure out how to improve health outcomes. And the evidence said, well, you need to change clinician behavior. In order to change clinician behavior, you often use clinical practice guidelines. But if you create them and nobody uses them, nothing changes. So you need to create a guideline and then get uptake. But if you're in a public health system and you don't have control over it, and you can't make people do things, you're not the military, you can't order them, how do you get people to create guidelines, have high uptake, but get them to voluntarily want to do it? So when I looked around the world, I found this gem in Canterbury. Had never been there before, knew nothing about them. But they'd figured out how to create hundreds of guidelines and get over 90% of their clinicians to follow them. It was an order of magnitude more than anyone in the world. But I didn't really believe it until I went down and worked with them for 6 months. And it's true, they'd figured it out. I got way more than I bargained for. I learned about clinical pathways, e-referral, acute demand, how to organize primary care. It was like drinking out of a fire hose. But the key message was called whole of system thinking, this idea of system integration. And this was a key change in mindset that helped facilitate everything that they did. So they have an amazing team, a number of unique talents that work synergistically together, and some of them are here today. But the other thing is they persevered. They've been together for a number of years. They've had a common goal, a common vision, and they've all worked together for a number of years to make it happen. The specific person talking today is Carolyn. The words I would use to describe her are visionary, a systems thinker, but she can also manage and operate and get things done. She's a master of herding cats, figuring out what to measure and how to balance demand and capacity, and where to strategically invest to get the biggest bang for the buck. It gives me great pleasure to introduce Carolyn Gullery from New Zealand.
Thank you, Rod. Thank you so much for inviting us here today, and of my colleagues down at the table, Ian, Emma, Graham and Janita. You'll hear from them during the day, and particularly when you ask me a whole lot of questions, we might be able to pass some of those answers to them. So what I'm going to do this morning is just take you on a journey, take you on the story of the Canterbury health system, give you a bit of an understanding of what we've done, where we've got to, how far it is that we have to go, and what we've achieved with some of the things that Rod's talked about. Because I think Rod's story of a patient missing out as he drops through the gaps in our system resonates with all of us. And I certainly won't tell you about a system that's perfect, and I won't tell you that we don't still drop people, but I will tell you that we're making progress. So, first of all, who are we? So Canterbury is one of 20 district health boards in New Zealand. We're the second largest district health board by population and by geographic size. So we're that red block there on the South Island of New Zealand. District health boards are funded by the New Zealand government and are responsible for planning, funding and providing health services to our population. So we plan and fund the whole system, and we own the secondary care hospitals and the public health system. So we provide secondary care services, tertiary services, public health services, and we fund primary care, so include general practice, pharmaceuticals, laboratory services, and long-term aged residential care. Canterbury itself is a population of around about 530,000. We have funding of 1.4 billion to do per annum to do all of that with. We have an employed workforce of about 9,500, and we fund probably about another 9,000 people across the Canterbury health system. We are the second largest tertiary centre in New Zealand, so we provide tertiary services for the whole of the South Island and the lower half of the North Island. The executive management team of the Canterbury District Health Board is also responsible for the West Coast, which is this little wee strip on the other side of the South Island, which is very long and very thin and sort of covers 32,000 people. So we're used to providing services in remote rural areas as well. So this journey that I'm going to tell you about, I'm going to start in 2007, but as you'll hear later on in the day, there are a number of precursors to what we did. In 2007, our system was broken. It was failing. We had failed to deliver on our elective services. We were in deficit. We ran a hospital in gridlock, which meant we had to cancel our elective surgery on a regular basis because there weren't any beds. We had unceremoniously dumped 5,000 people off the waiting list the year before because the government said no one could wait longer than 6 months, and we couldn't come up with any other way of solving the problem except sending 5,000 people a letter to say they weren't on the waiting list anymore. So that was 2006 going into 2007. We did have some strengths. We had a very, very well organised primary care system and a lot of skills and capability in the system, but the system was broken. It was fragmented. It was broken up by contracts and transactions and long-standing arguments about whose money was whose and who gets to spend it. We did a piece of work then, health services plan, and out of that we got some really key metrics. Those key metrics changed the way people looked at the health system. The first one is if we kept on doing what we were doing, then by 2020 we were going to need another hospital the same size as the hospital we already had. so another 450 acute beds. We were going to need 20% more general practitioners, and at that stage our GP's average age was 52, and this was in 2008, so we didn't think there'd be that many of them around by 2020. And we were going to need another 2,000 long-term aged residential care beds. We were already spending $140 million per annum on aged residential care, and we're thinking, where on earth is the funding coming from? But actually we didn't make it about the money. You don't hear people in Canterbury talking about this is about saving money. In fact, we very rarely mention that. What we realised is if we did all of that, we'd need another 8,000 people in the workforce. And in the South Island of New Zealand, we have that classic demographic of the ageing population and the increase in people over the age of 65, while the next cohort coming through is actually smaller. So we knew we were going to have a workforce crunch anyway, but when we looked at that and realised that in less than 12 years' time we were going to need another 8,000 people, we knew that wasn't going to happen. So something had to change. So we went through a process with all of the people in our health system. A Vision 2020 we called it. We were being slightly amusing at the time. Vision 2020. Got a lot of people in a room. We showed them the rest of the world. We showed them other things that people do. We talked to them about how the bus company worked, how airports worked, how systems worked. And we got them to come up with a vision of a different health system, a vision of a system that was a connected system, connected by IT, connected by information, but most importantly, connected by relationships. A system that was centred around people, and a system that aims not to waste their time. So the entire unifying metric across the Canterbury health system is don't waste the patient's time waiting for the next step in their journey to well health. So everything we do is to reduce the amount of time that patients spend waiting. So that was nice. We had a vision. It was a connected system. How did we make that happen? So we came up with 3 strategic goals. Now, we took this to our board in 2008. In 2008, our board wanted to build a new hospital, because all good boards want to build new hospitals. Instead, we said, look, let's not do that. Let's instead set about changing the system. So we'll ask you to sign off on these 3 strategic goals. 1, build a system that develops services to support people to look after their own health and wellbeing. 1 that develops primary and community services to support people in their whānau, which is Māori word for family, in the community-based setting with a single point of continuity, which for most people will be general practice. And the 3rd is free up hospital-based specialist resources to be responsive to episodic events, providing complex care and supporting primary care to do their job. So a complete turnaround of the system. Now in New Zealand, just to make this a little bit more complicated, patients pay to go and see primary care, and of course the hospital's free. So actually, how do you get patients to see general practice as their point of continuity when the emergency department's free? We also developed a new way of working. We got rid of the whole conversation about contracts and funding and price volume schedules and all of the other interesting mechanisms that all health systems have used all over the world to try and drive change. We said, no, we're going to run a health system based on trust. We're going to run a health system based on there is only one health system, because from the patient's perspective, there is only one health system. They don't care how we've chosen to organise it. And there is only one budget, even though there isn't. There's a lot of funding mechanisms in our health system like there is in everyone else's. But if we act as if there's only one budget, if we act as if there's only $1 and we can only spend it once, and we stop fighting at the boundaries about whose money it is, maybe we'll get it right for the patient. So we made it about people, about not wasting their time. The District Health Board stepped away from being the policeman of the system that told you what you were and weren't allowed to do and tried to tell clinicians how to do their job on a day-to-day basis, to being buying the right thing but enabling clinicians to do the right thing for patients. And we moved into what Rod talked about, the whole of system approach. And that's understanding and responding to the needs of a population. It's managing the short term in the context of our vision, And it's in focusing on improving productivity by doing the right thing at the right way and the right time, and not by doing more of everything. And making all of our decisions based on what's best for the patient and what's best for the system, and how do we balance those two tensions. And we started talking about health as a resilient system, not about a hospital. There are a lot of things that have driven the change in the Canterbury health system, and during the next few days you will all get, those of you who will be around will get to hear more detail about some of these. But just to give you a bit of a feel, we have a training program that we've developed for ourselves, that we run for anyone in the health system. It doesn't matter who they work for, and it doesn't matter if they're a manager or a clinician. It's called Accelerate, and it teaches people how to drive change. It's open to all health system staff, and they work together, and they get an opportunity to understand how you make a system work. At the end of it, they get to go to David's Den. David's our chief executive, and they get to pitch ideas to David's Den, and those of them who pitch a good idea get it backed by the executive management team, and then they get to go and change the world. They also get a permission card. That permission card says, you have my permission to change the health system. Because the entire drive of the Canterbury health system is to enable everybody to make it better, not just according to the project or who the governance group is, but empower everybody to do the right thing. We also have the Canterbury Initiative. Now this is particularly important because this was the underpinning of health pathways. This was how we drove the connection between primary care and secondary care. This was the response to kicking 5,000 people off the waiting list overnight, and so all saying to ourselves, that's never going to happen again. And this is about getting primary and secondary care clinicians in a room with a blank whiteboard and saying what doesn't work, and then fixing it. So it's a way of working that's sustainable over time. Now the people in the Canterbury Initiative, and you've got one of the main people in the room today, which is Graham. So we had 2 GPs and a civil engineer. And they just went around, got people in a room, figured out what was right, figured out what was wrong, and we fixed it. Really simple process. Not a lot of performance administration, permission seeking, we just fixed it. But there was a little bit of a trick to that. Having fixed it, how did we let everybody know we'd just changed the health system? So that's where Health Pathways came from, which was a way of documenting our agreed ways of working. So when we changed the way the system worked, we had to document it somewhere. We needed to document it somewhere where it was easy to change and was easy for everyone to see. Now, guidelines, we've all gone through the whole guidelines process. This was different. It was designed by the people, for the people, and they used it. So in Canterbury now, Health Pathways is viewed about 1.3 million views per annum. So about 1.3 million times a year, somebody in the Canterbury health system jumps into Health Pathways to find out what they can do and how they should do it and what telephone number they need to ring and what's the right thing to do to help the patient in front of them on their journey. It's systematically developed, reviewed, updated. All of the process that sits behind it is tight. But it also means that today, it's right. So if you're a general practitioner sitting in your general practice today seeing a patient and you go to Health Pathways, you know that the information on Health Pathways will be right. Of course, if you think it's not right, you can always send feedback. And that's how we keep them current and up to date and absolutely relevant. And it's done by connected multidisciplinary teams who work across the system, and they have conversations by email, and we know what's going on and we trap it all so that we actually know how the pathways each develop. It's now working across about 24 systems. It's accountable for about the healthcare for about 15 million people across Australia and New Zealand. So somehow the system that we developed in Canterbury to deal with our problem has managed to scale across multiple health systems. And actually with the recent changes in Australia, it'll be close to 20 million people who will be covered by Health Pathways. But each of those health pathways are localised for that system because they're relevant for that system. It's also a way of bringing a system together in a reliable way that can be reproduced over time. We also built a few other things. Electronic request management system was designed to enable general practice to refer to everywhere else in the system, to meet that goal number 2, make general practice that single point of continuity. So it actually refers from general practice to every other point and back again. Connects up an entire health system, but from my perspective collects all the information in the middle so that I can use that information for planning and for figuring out what it is that we need to deliver for our health service. Health info is like health pathways, it's just the patient-facing version and provides the information that the patients in the Canterbury health system need to help them manage their own care well. Alliancing. When you're running a public health system, you still actually need contracts because the Office of the Auditor General gets quite antsy if you just give out money without any kind of documentation behind it. So we needed a contract that actually fitted the way we were working, which was based on the assumption that most people each day go to work to do a good job. And if they're not doing a good job, it's because we made the system wrong, not because the person's wrong. So we borrowed alliancing from the construction industry. So the thinking behind alliancing is that we're all working together to achieve the same goal. So instead of the district health board saying, yeah, we have the money, we make the rules, it was actually about everyone working together, and it also enables us to create a truly clinically led system. Because the leadership team of the alliance are clinicians. And they sit and they make decisions about where the best place is to allocate resources across the system, and then it's the job of my team to make it happen. It is a contract, it's a good faith contract, but it's a perfectly legal contract, and it's high trust, low bureaucracy, and it enables you to change on speed. Because actually you can decide today that we want to do it differently tomorrow, and as long as we're delivering the same outcomes and we're using the same resources, then we can do it a different way. So the way it works in Canterbury is we have an alliance that drives all of the transformation. And underneath that is a whole range of work streams and service level alliances that focus on different parts of the system, with the overall alliance leadership team keeping everything connected. And it works because everyone trusts that the DHB, through its planning and funding function, will deliver what the alliance has agreed needs to be done. And it enables us to focus on managing cost and delivering outcomes, not worrying about chasing the revenue, which was what was crippling our system previously. It enables and is enabling of the whole clinical pathways, collaborative care, shared patient records. We did have a slight disruption to our journey about 2010, 2011, when we had some fairly major earthquakes. A number of people think that the Canterbury health system is a consequence of the earthquakes. As you already now know, we started this journey long before those earthquakes, and if it wasn't for what we had already done, then those earthquakes would have devastated our health system. Because we lost acute beds, we lost aged residential care beds, we lost general practices, we lost pharmacy, we lost power, we lost water, we lost sewage. We still managed to run a health system. Because we were able to get it up and running, and we ran it on trust, and we changed the system as fast as we needed to, and we used health pathways to keep the whole system connected. We did get some gains out of an earthquake, which was a fully integrated electronic health record. Everyone's dream, which in all good systems has been a challenge as to how you get particularly general practice and secondary care to share clinical information. What we've managed to do is build a secure system that pulls the data off everybody else's system, creates a view, which means wherever you are in the Canterbury health system, if you're a general practitioner or a secondary care clinician or a pharmacist, you can log into this and you can see everything that everyone else knows about the patient in front of you. It is transformational, being able to see right now everything else that you need to know to provide care to the patient in front of you. It did take us about 12 months to do. Most of that was arguing about who got to see what information and getting agreement amongst all the various professionals as to who was allowed to see what about whom. But then we built the technology. So right now we've got actually over 500,000 Canterburyans have a shared electronic clinical record. It's an opt-off system, and about 200 people have chosen to opt off. And everyone else is quite happy to have their information shared. The big change that we're driving now is data. Because we have done everything we've done in the background by using lots of information to plan and drive a health system, now we're shifting that information to the front line so that everyone on a day-to-day basis can see how the system is working and make decisions in that context so they do better today and better tomorrow. So we've now really ramped up the pace of fast cycle change so that our surgeons can decide they want to deliver in a different way this week, and they can know next week whether it's made a difference or not to patient flow. And we use journeys, patient journeys, as our core metric. So we follow the patient through the system and measure at each point where our opportunities are to reduce that amount of time that they waste waiting. This is just a visualisation that we use, which has then got a whole range of metrics attached to it, so that everyone in the health system can actually see how long patients are taking at each point in our journey. We've got a range of other programs that we use too that actually enable what we do in Canterbury. One is the Acute Demand Management Service that predates the 2007 change, and it was probably the beginning of the real engagement between primary care and secondary care. It's when general practice started to take responsibility for making sure that only the right people got to hospital acutely unwell, and other people who didn't need to be in the hospital didn't get there. And we did that by enabling them to do a whole range of things in a community-based setting, fully funded by the District Health Board, that they previously couldn't do. So every year in Canterbury, 30,000 people now, it says 28,900, we just hit 30,000, 30,000 people get their care in their own home instead of in a hospital-based setting. We now have a complete wraparound service. This came out of the quake as well. We were going to do that, but after the quake, when we'd lost 630 aged residential care beds and 105 acute hospital beds, we were a little bit tight on space. So we needed to figure out how could we get people home and rehabilitate them in their own home really quickly. So we developed a new model. We did it as an alliance. It's delivered by one for-profit and two not-for-profits, and the public system all working together. It took us 3 weeks in an alliance framework to go from concept to delivery. And medication management service. Getting pharmacists engaged and making sure that people are taking their medications, it's the right medications, and they're taking them in the right way, and we're making best use of resources. And our falls prevention program, a whole of system falls prevention program, where actually everybody in the health system has an accountability for making sure that the person in front of them is able to stand up without sort of leaning on the chair. And recognising where people are at risk of a fall, we can actually trigger a response. So it doesn't matter if you're a pharmacist or you're a physio or a GP or you're a nurse working in a rest home. If you see someone who's at risk of fall, you can trigger a service. We've looked after over 5,000 people in this service over 3 years. The results? In the last 3 years, 1,000 less people over the age of 75 have arrived in our emergency department as the result of a fall, and there are 383 less fractured hips as a result of a fall. And if you follow that through, then there's probably about 83 people still alive who would have died when they fractured their hip. Remarkable. Then, of course, from the other perspective, it's cost us, we do sometimes talk about money, it's cost us $1.8 million to deliver that program over 3 years, and it's saved us more than $18 million in avoided cost of fixing all those fractured NOFs. So, I've started to sneak into results. It's all very well to talk about this, but does it work? So what does it mean for the people? Firstly, who are our people post-quake? So people think some of our remarkable results happened because we had an earthquake and everybody left Canterbury. I can actually tell you that our population now is about 60 to 70,000 more than it was when we started this journey. So it's okay, they didn't all run away. But what did happen is that immediately post-quake, we actually lost the workforce. The older people stayed, and in fact, we actually ended up with more of them. We're not quite sure why, but we did. I know we all feel older, but somehow or another we actually ended up with more older people. But the workforce left. So that was the big hole for us. We lost about 5,000 people in the working age population. That's all been replaced since. And as I said, we're now sitting at a much higher population than we were previously. And it continues to age. So about 16% of our population is over the age of 65. And we actually have the biggest population over 75 in New Zealand. And we'll continue to do so. So people have shorter waits for care. It's all about saving the patient's time. Just in 4 programs, when we were sat down and worked it out, we'd saved 1.5 million days over 3 years of patient waiting time. And that's using health pathways to redesign the system and get the right care delivered in the right place and enabling general practice to do what they need to do and avoid having people come to hospital unless that's actually where they really need to be. We're now down, we're close to 100 days wait maximum from referral to a specialist assessment and from a specialist assessment to surgery. Close. It's about 110 at the moment, but we're on the way. People are able to stay well and self-manage in their own homes and communities. Now what this is the graphs that we use all the time in Canterbury, and they're based on statistical process control. So to give you just a little bit of an idea, the green line in the middle is the median. The red lines are the control limits. They're sitting at about 2.7 standard deviations away, but 99.7% of your points should fall between those lines. The blue line is what actually happened. And what you can see here, this is the actual number of occupied beds in our acute service, both medical and surgical. And you can see here that instead of the old way of we were going to need another 450 beds by 2020. In fact, we've actually held the occupied beds flat. And we've continued to hold them flat. And we've now held them flat for almost 5 years, despite that population now being 70,000 more than it was. In particular, we have made a difference to older people, because that's where we started, because older people, because we pay for age residential care, because more people, 66% of the people in our hospital for an extended period of time are over the age of 65. If we could get a handle on how to provide better care to older people, then in fact you start to solve all of your other problems as well. So what's happened? ED attendances for older people, that dotted line is what would have happened if life had continued the way it was going. The green line is what's actually happened. So actually our ED attendances for people over the age of 65 are less than they were in 2010 and have stayed flat now from 2010 all the way to 2015. So in percentage terms, at our worst in 2007-8, we had 27% of people over the age of 65 arrive in our emergency department. We're now down to just over 22%. So we're not there yet, but that's a significant improvement. And why don't they arrive in our emergency department? Because they get looked after in the community by their general practice team, and they get early intervention and they get well faster, which also means that they spend less time in our hospital. And if they do arrive in our hospital, we've actually managed to reduce the amount of time they stay there. So one of our measures, one of our newest measures in the system, which has only been running for 18 months, is the number of beds occupied by people over the age of 75 who've been there more than 14 days, because we have both a rehab hospital and an acute hospital, and as well as mental health facilities. So what we've done here is we set about driving a change to reduce the amount of time that people spent in a hospital bed, because we all know that keeping frail older people in a hospital bed is actually not good for them. And in 12 months, that break that you see in that graph is where we started the new process. So in the space of 12 months, we've actually saved 30 beds a day. So every single day in Canterbury, there are 30 less people in our hospital over the age of 75 who've been there more than 14 days. And no, they're not coming back. We're not kicking them home faster. and then having them cycle back into the system. So we measure readmission rates, and we measure readmission rates at 3 days and 28 days just to make sure that when we got them home and we gave them CREST, which is a nice wraparound service, we got them back on their feet, we rehabilitated them, and they didn't end up back in our hospital. But what they also means, and what's really important to us, is that less people over the age of 65 are now ending up in long-term care. So what's happened is that where we were actually heading, which would have had 2,000 more people in aged residential care by 2020, which is 1,000 more people by now, we actually have 400 less. And when they do get to aged residential care, they stay less time, because actually we've been able to look after them in their own home for longer. So by the time they actually need long-term care, it's really towards the end of their life. What does that mean financially for those of you who are financially oriented? In this financial year, we will spend the same amount on aged residential care as we did in 2006-07 in absolute numbers, absolute dollars. That creates a whole lot of extra resource to spend in the rest of the health system. So other things, chronic obstructive airways disease. New Zealand's not really good at this one. I think only Ireland was worse than us in terms of putting people into hospital with chronic obstructive airways disease. We decided that wasn't good enough, so we redesigned the system. And we actually ended up giving the ambulance officers the permission to trigger an acute demand response, or take the patient to general practice, or take the patient to our 24-hour primary care service, rather than taking them to ED, which actually meant we saved, this year alone, we're going to save 2,000 bed days, because those people with chronic obstructive airways condition aren't either getting to our hospital, if they get there, they get home faster. So it's all about keeping people well and healthy and in their own communities and out of our institutions. And we don't acutely admit as many as... It's all very well for me to talk about this, and I've told you we've come from a really, really bad performing position, and we're now in a good position. How does that compare to the rest of New Zealand? Because that's the only comparator that sort of stacks up, because it's the same context. So in Canterbury, our admission rate, age standardised, is actually 30% below the rest of New Zealand. So if we were admitting at the same rate as the New Zealand average, then we would have had 15,000 more people in our hospital last year. And we would have needed another 100 beds in our hospital, which incidentally we don't have, but we would have needed another 100 beds in our hospital. But that hospital that used to be in gridlock regularly and cancelling elective surgery all the way through winter, now never goes into gridlock. In fact, none of us can remember what gridlock is. I think if we started talking about gridlock, about half the hospital staff would go, what? And what do we do? Because we just don't have it anymore. In fact, generally speaking, in a city that now has 60 to 70,000 more people, a whole lot of them over the age of 75, we run our acute hospital every day with a spare 60 beds. And we have less beds now than we had before the earthquake. So we've actually learned how to manage a system and keep people going through that system with pace. And what it means is more of our activity is now elective. So we meet our elective targets instead of failing to meet our elective targets. And we've had a 43% increase in access to elective surgery for our population, but without any increase in the occupied beds, because we've reduced the amount of people spending time in beds for acute medical issues. We've got room to bring those people in for surgery. So we've found that if you get the whole system to work, it doesn't matter that a lot of it's broken and a lot of it doesn't work perfectly and things fall over, because actually it all compensates for itself and the entire system works. And if we've got a problem in one part of the system, then the other parts of the system step up to help. So when our hospital does start to get full, general practice does more. We can literally turn on a better response from general practice today at 11 o'clock in the morning. We can just say, hey, the hospital's getting tight, can you guys pick up a bit? And it will happen. Vice versa, when the 24-hour surgery that looks after people acutely unwell in the primary care setting, when they start getting tight, because they're actually running out of physical space now, they can ring up ED and say, hey, can we divert? And ED picks up the load, because everyone works together, because it's all about the patient. Now, one of the last things I'll touch on is our health outcomes framework. Because one of the interesting things about an integrated health system is how do you measure it? Because nobody's actually figured out how to measure integrated health systems yet. And that's something that the King's Fund commented on, is how do you measure an integrated health system? We didn't know how to either, so we built our own systems framework, because it's not linear, it's not in straight lines. So we start off with what we're trying to achieve, Canterbury people well and healthy and in their own homes. How we're achieving it? By a connected system centred around people that doesn't waste their time. Then we have a whole range of system level outcomes that are connected to that. One of them, for example, is the increased planned care rate and the decreased acute care rate. And we link a whole lot of dashboards to that allow us to keep track of whether we're actually achieving what we set out to achieve. And this is how we report to our board. So we have things like decreased avoidable mortality, and that we count that. We count that in terms of inside the hospital, and we also look at post-discharge, 90 days, 180 days post-discharge, as well as all-cause mortality for people under the age of 65. All of which we do by ethnicity and deprivation, so that we can make sure that we're not increasing the inequities that inevitably exist in our population. So that whole outcome framework actually enables us to take it right down to the front line, and we'll talk a bit later about that in another session, but right down to the front line, so I can actually tell the nurse on Ward 27 what it is that she's doing today that is contributing to the outcomes of the Canterbury health system. And she can see that by logging onto our intranet. She can have a look at the outcome metrics for Ward 27 and see how it is that she's making it work better for the entire health system. So, are we the only people that think that what we're doing has actually really worked for us? This comment came from David Albury, who some of you may be familiar with. He's the board director of the Innovation unit in the UK. And he's been to Canterbury and he's had a look at what we do, and he's looked at all of the things that we've got that build the change that we've built. And he was actually quite impressed that we've actually managed to do this. I think the thing that actually gives me heart is that we started this journey in 2007, it's now 2015, and I keep on waiting for the other shoe to drop, that all of a sudden something will happen and things will start to go in the wrong direction. But actually every time we look at the data, it's actually holding together. And are we there yet? No. We're an awful, every day you put your head in your hands and think, oh, how on earth could we have done something like that in our health system? But what we are pretty clear is that this is actually a journey worth taking, and that it is possible, and we can keep on making our health systems better. Thank you.
Thanks very much, Carolyn. We have time for questions, and rather than having people line up at the mic or whatever, if people wanted to just to note to Jasmine or I if they had a particular kind of question, I can run the mic to people. I'm sure there may be some comments or questions from people in the audience.
Thank you very much. It was excellent. I have a question, and I wanted to know, Caroline, if your family practitioners, you mentioned if you have a need for them to ramp things up, they can do it fairly quickly. They're obviously part of your biggest integrated system, and they're really, I can see a central point, the beginning point of everything. Now, are they employees of the district or the government, or how does that work with the family physicians?
Thanks very much. That's a really good question. It's always hard with this kind of audience to know how deeply to go into the detail. So the general practice is private business. It's funded by the District Health Board, or partially funded by the District Health Board on a capitation basis. So the population enrolls with general practice and we pay them a per capita rate adjusted by age and gender. They also charge the patient a co-payment, so about 50% of their income comes directly from the patient and about 50% of their income comes from the government via the District Health Board. And they're in an organisation which is also funded by the District Health Board called a primary health organisation, which provides them with the underlying infrastructure and keeps them together as a network. There's 126 general practices in Canterbury and roughly between 500 and 600 general practitioners. So bringing them into the system was one of the paradigm shifts that we made, because prior to in the 2007, general practice was out there and the District Health Board was effectively functioning like a district hospital board, with much more focus on the bit that it owned rather than the bit that it funded. So this was actually part of the whole change, was to try and stop that battle going on between the funded part of the system and the owned part of the system, and actually say we're all in one system.
Tracy's just on.
Thanks, Carolyn. Great to see it from a couple of years ago, even just the great improvements. I'm interested in, given Canterbury having a tertiary service, you obviously would draw patients from other provinces. And so I'm sort of thinking of our Alberta experience or Canadian experience. Can you talk about that transition? How do you manage the transition of patients coming in, because you're a referral center, and how that whole system thinking transcends to the other surrounding geographies that you're working with?
Thanks, Tracy. So, yes, we are the major tertiary hospital for the whole of the South Island, and also we do a lot of the secondary care for the much smaller DHBs around us. What's actually happened is, first of all, it's always about the patient, so therefore there's no differentiation about whether this is one of our patients or one of their patients. It's all our patient. What we've done is Health Pathways has now moved across the whole of the South Island, and the whole of the South Island has joined another alliance. So we've created an alliance of the district health boards in the South Island, so that the ways of working that actually we initially developed in Canterbury are now spread out across the whole of the South Island. And a number of the models that we have are being replicated in other district health boards. And we also have South Island-wide pathways for those secondary to hospital type transferals. And we have groups of clinicians from across the whole of the South Island now deciding how patients who require to be transferred between the hospitals, how that's going to happen. And the next level of that we've just started on, which is, for example, we've done it with bariatric surgery, where we're running a single South Island-wide patient waiting list. And so essentially, even though each DHB is funded for its population, we've pulled the money and just said it's whoever is clinically needs it the most will get the next, even if it's not necessarily from where the funding's coming from. So that whole concept of actually using the money in the best possible way to deliver the right care to the right people is transcending district health board boundaries.
Thank you, Carolyn. What an inspiring talk this morning. So perhaps to just build a little bit on what Tracy was saying. So, you talk about patients not wanting to waste their time. So how have you successfully integrated the patient voice and the family voice in the work that you're doing around clinical pathways?
So that's also a really good question. And I think we're on a journey on that one. So the District Health Board has a Consumer Council, and the Consumer Council we work with on any of our new redesigned processes and services. They're also involved in the Alliance Leadership Team, so consumers are represented in the Alliance Leadership Team and in the service level alliances and all of the work streams. And when we're doing a lot of our design processes, because we have a design lab, which I didn't touch on, but we have which is a big warehouse, that we use for a lot of our redesign. So consumers are involved in that, and consumers are involved obviously in health info, and they're also involved in the pathway development. So it's constantly bringing consumers into all of our work. And the Consumer Council acts as that oversight governance group, but also that supporting infrastructure for consumers, because it can be quite scary for consumers to get in a room with a bunch of clinicians and then have a debate about how diabetes is going to be delivered. So the Consumer Council provides them with that support to enable them to engage, and also we provide them with training and education so that they can join the conversation on in a more even way.
Just, and I know someone else, I just had one question around the performance reporting. Is often in systems where clinical practice performance is reflected back, it's often reflected back just to practitioners for them to evaluate. Is the performance of various practices against clinical pathways public? Is that kind of transparent in terms of how different people are performing? So I was wondering about the transparency of that particular kind of process, and is there any incentives associated with achieving clinical practice improvements or performance that are fit into the financial system for those general practices of outcomes-based funding at all?
So I might have a quick look at Graham to answer the whole how do we feedback on clinical practice and improvement. That's probably a good question for Graham. In terms of incentives, there are some incentives related at a national level around performance on certain things such as CVD risk assessments and things like that. But generally within the Canterbury health system, we avoid financial incentives like the plague. As far as we're concerned, financial incentives in a complex adaptive system inevitably become perverse. So the rule is that you actually don't lose, but we don't use financial incentives to drive performance. What we do is we actually organise the funding to make sure it's not a barrier to doing the right thing, and we actually find that the drive to do the right thing is far stronger and a much better way to go. So we don't use financial incentives. But Graham, do you want to comment on the practice?
Great. Here.
We're not particularly transparent about our different clinicians individually. We don't report league tables of surgical results by surgeon. There are other places that do that more than we do. As far as feedback goes, for many years in primary care, general practitioners have received information about their pharmaceutical utilization relative to their peers, their laboratory utilization, and we're more recently feeding back on their referral behavior, so how they manage their population. And because we have an enrolled population, we can relate that to their demographics and give pretty meaningful feedback about the difference in referral as a behavior, which has been most interesting for our clinicians. We also clinically audit a lot of the pathways, particularly where we have changed the direction of care. So if we've moved a service into primary care from hospital delivery, then we measure case by case and then try to automate the data collection so we don't have to wade through the clinical records if we want to repeat that audit. So we do measure and monitor at many levels and feedback as much as possible.
So what we're also capable of doing with our data systems in the hospital and with those kind of graphs is we can actually break those down. So, but we tend to use them with the clinicians as opposed to publicly using them. So I sat down with the orthopaedic surgeons not too long ago and gave them a view of how long it takes each of them to do a hip replacement. It's quite interesting, the variation. But actually what we're doing is providing them with that information to enable them to drive change and service improvement. So actually within our data systems, they can get a whole lot of detailed information. And so we're taking them down the journey of engaging with that so they can actually see how they can do better. It was quite fun telling the respiratory physicians that they kept people with COPD on average 2 days longer than the general medicine physicians did. They did try to tell us it's because they had the more complex people, but actually no, when you looked at the data, it was the other way around. The more complex people were in general medicine because they were the people with the comorbidities and they were older and frailer, and the simpler ones were in respiratory, but there you go.
Carolyn, thank you. Can you describe the process and practice around scaling Canterbury pathways outside of Canterbury?
That's a very big question. So that's actually what the team down here do, and we take it to other places such as Australia, and we take people through a training program which looks a little bit, the beginning of the training program is actually that presentation, and then there's a whole range of other presentations that they get through the day, helping them understand how you do clinical redesign. And then on day 2, they get more into depth detail about how you write pathways, and then the team here walk alongside the systems and help them develop the tools. We teach them how to do the engagement, the Canterbury Initiative type approach, and how you get people in a room, and then how you actually redesign a pathway. What we've found in terms of rolling out health pathways is we end up with two kind of things go on. So if people start with a copy of the Canterbury Health Pathways, because there's a lot of really good clinical information in there, and even if it's the wrong telephone number, the clinical information is usually pretty much similar no matter which system you go to. And then people localise those quite quickly so they get a whole lot of pathways running fast. And then they can focus on the redesign, which of course is where the real value add is. So the first thing that health pathways give systems is a reduction in variation, because people start to follow the same pathway. And therefore you've got more certainty that when a patient goes to a particular primary care provider, they're going to get the same kind of response. The second thing you can do and then is redesign your health system and actually move where care is delivered and how care is delivered. So those are the 2 phases. So there's a gain in the first phase and then the big gains in the second phase. But there is we've got a whole program workbook strategy about how and now we've rolled it out in 23 systems now in both New Zealand and Australia, and so we've got it pretty sussed.
Thank you, Catherine. I think what you've been able to achieve is amazing within a short period of time. My question relates to pathways development. How is it supported and maintained? Is it supported by the government, by the health authorities, or just by individuals supporting their time?
So in terms of financially supported, it's supported by the health authorities, so whichever they are. So each of the district health boards in New Zealand makes the choice to participate in health pathways. And the same in Australia. It's been either the Medicare locals, which are now primary health networks, and the local health districts, which are the hospital-based systems. So they actually support it financially, and also, but it keeps going. I have to say, we were at a conference a few weeks ago in Australia, and what we saw there was a huge amount of enthusiasm from the clinicians, and that's what keeps it going. Is the clinicians are the people who own it. They own the pathways. It's governed by them. If you go through our health pathways, you'll see that actually we have the owners, and the owners are the group of clinicians that help develop those pathways in the first place. And that's what keeps it going. We had a session in New Zealand, in Canterbury, about refreshing our direction and our vision. And our head of radiology just turned around and said, one thing, I don't want to go back.
Now that you're so far along in your journey, if you looked back in the last number of years, would there be anything that you would do sooner and faster? And is there anything that you wouldn't repeat?
Oh, that second one is a little bit tricky, that one. The first one, I know how I would answer, but I suspect my colleagues would answer differently. I'm not sure what Graham would say, but for me it would be I would have got onto the data faster. The biggest, what we can do now with data is so much more than what we could do 7 years ago. And it's just adding so much value and so much pace that I would have sorted the data stuff out many years earlier. That's certainly what I would have done. Graham wants to put in his view.
In 2003, we did the acute demand program from primary care to the hospital, and there were a number of unintended consequences from that. And we learned then to bring everybody together rather than just doing it in primary care or just doing it in secondary care. And we knew we needed to do community-based rehabilitation at that time. We were keeping all these people in the community, but we didn't have the community-based rehabilitation services. So the place to start is getting the acute demand under control, but adding in those community-based rehab services, because we caused issues to our aged care services by keeping people in the community who would normally have gone into hospital.
Okay, thanks. Actually, that was related to, and I have the mic so I can have the last question because we have to finish at 9 o'clock. But there is, I know, the great work that's underway. And I think we're finding in Alberta a lot of the solutions to support individuals are not only community rehab, but mental health and addictions, social care supports. And I'm wondering what impact your system has had, or the relationships with not downloading, but providing increased clientele to those particular services, and are they partners in the alliance, those kind of supportive services, which are the non-healthcare, non-medical related, and what's that relationship has been?
It's actually a really good question, and I didn't really touch on mental health, but we've redesigned the mental health services in much the same way, and it's certainly completely changed the dependence on inpatient activity in our mental health facility. We were a little bit behind on that one. Yes, absolutely. The NGO sector and the social services sector are part of our alliance type framework. Some of those services we fund, some of those services are funded by other government agencies, and some of them are funded by charity, etc. So they're all part of the system and the design. And have we increased the load on them? Yes, we have. So a lot of the tension for us is actually trying to keep the system balanced now, because what we find, we still have that workforce problem that I was telling you about. You know, we needed 8,000 more people in the workforce. And so trying to keep that system balanced, because we run into workforce constraints in various parts of the system. And the big issue for Canterbury right now is that we lost nearly 11,000 homes in those earthquakes. So we've got a homeless problem that we didn't previously have, and we've also got a workforce gap in the kind of workforce that you need for those kind of social services, because they can all go and build buildings. So yeah, there's a lot of issues in that area.
Well, thanks very much, and thanks. I think the lessons from your experience are going to be very impactful, I think, in our province, and I'd like everyone to join in thanking our guest speaker.